Ma'am, Edwin, madam, would you like to present the next case, ma'am? There's some issue there. By the time they come back.
Valar, I wanted to ask actually a few things for that case. What happened suddenly it stopped?
Ma'am, there's some connectivity issue, ma'am. திருப்பி அவங்க வரதுக்கு கொஞ்சம் லேட் ஆகும்னு நினைக்கிறேன். அதுக்குள்ள can we go on to the next case and
Okay.
Ma'am, sir.
சொல்லுங்க மேடம்.
Sir,
Swaminathan, did the patient have thrombocytopenia?
No, ma'am.
No,
ma'am. This patient didn't have thrombocytopenia, madam.
Okay. Because something about consumption coagulopathy was mentioned
Yes,
there.
Yes, but this patient just present with an incidental finding a long-standing problem, madam. We are following the case. She will be presenting, ma'am.
Yeah. Okay.
Can I be allowed to share screen once again, ma'am? I have few more slides left.
Yeah. Okay.
Sorry for the interruption.
Each presenter will be presenting for 6 to 7 minutes. Make it as brief as. Okay. Continue. Ma'am, Edwin, ma'am, konjo, ma'am, let her present, ma'am.
No problem.
Okay. சக்தி பிரசன்ட் பண்றீங்களா? Yeah, Dr. Sakti, continue.
Yes, ma'am. I'm unable to share my screen, ma'am. Can I continue, ma'am?
Wait.
Yeah, okay.
Is your network okay? You can always share your screen. What's your issue?
I have a good network here, ma'am. It's fine now, but I am still not able to share my screen. Okay. Ma'am, I can finish it without my PowerPoint, ma'am, because we have only a few more points left to be telling, ma'am. So I can continue it. Essential diagnostic criteria as proposed by WHO. It is going to be either superficial dermal lesion, tufted angioma pattern, or deeper lesions, kaposiform hemangioendothelioma pattern. If it's going to be of cannonball-like appearance, discrete lobules of capillaries, it's going to be more of superficial dermal pattern. And if it's going to be ill-defined coalescing nodules with those crescentic vessels and lymphatic component, it will be kaposiform hemangioendothelioma pattern. And immunohistochemistry, as summarized, it's going to be CD31, ERG, and CD34 positivity, and podoplanin, LYVE1, and proxone positivity in case of lymphatic component. And prognostically, untreated lesions of tufted angioma is going to undergo fibrosis and spontaneous regression. It may recur, whereas kaposiform hemangioendothelioma is not going to be associated with spontaneous regression. Larger lesions, they are associated with more mortality due to Casaback-Merritt phenomenon. Our patient didn't have any thrombocytopenia, both preoperatively and postoperatively. Hence, she hasn't gone for any complications. And we can perform wide local excision, and there are also medical therapies which are available like vincristine, steroids, and mTOR inhibitors, which are also promising. And no distant metastases have been reported so far, but few cases of lymph node involvement is rarely seen. So to conclude, why have I presented this case? So I've presented this case for rarity. In terms of age, most commonly this tumor was supposed to occur in infancy and childhood, but ours is a 29-year-old adult. And the rarity of clinical presentation, most commonly it should have occurred as some violaceous plaques and patches, but in our case, it was a subcutaneous tissue. And knowledge about both of these tumors is essential to consider it as a differential diagnosis for the vascular tumors, so as to early identify it and prevent the patient from going into Casaback-Merritt phenomenon. So I thank you so much, ma'am. I had posted my references as a WHO, Fletcher, Enzinger, and a few journals from the Google Scholar, ma'am. Thank you so much.
What is the malignant potential of this case? What is the malignant potential of this tumor?
Intermediate malignancy, ma'am. Rare
Intermediate.
lymph node metastasis is seen in cases of kaposiform hemangioendothelioma, ma'am.
Okay.
Thank you.
So that thank you, Dr. Sakti. That was a beautiful case. Any questions
ma'am.
for discussion? Can we go on to the next presentation, ma'am? Elviri, ma'am, are you ready, ma'am?
Yeah. You can
Somebody's mentioned.
put my ordering. Good morning, everyone.
Just a minute, ma'am.
Yeah. பேச ஆரம்பிக்கிறதுக்கு முன்னாடி இல்லைன்னா விக்ஸுக்கு ஹார்ட்ஸ்க்கு என்ன டிஃப்ரென்ஸ் வருது?
Ma'am, you can start your presentation, ma'am.
It is not seen in the in sharing. You're not. Oh. வரலையே. Yeah, you're doing it, no? வளர்.
Ma'am. சொல்லுங்க, ma'am.
வரலையா? ஓபன் பண்ண.
Screen sharingல தான் மேடம் இருக்கு.
இல்லையே.
Unless you make them co-host.
Yeah. Good morning, everyone.
Ma'am, can you see the screen?
Yes.
Then continue, ma'am. Welcome,
can
ma'am.
you hear me? Can you hear me, Vala?
Yes, ma'am. நல்லா கேக்குது, பேசுங்க, madam.
Okay.
Good afternoon, madam.
Good afternoon to everyone. I just wanted to present a interesting case of adrenal incidentaloma, unmasking the mystery behind. And Dr. Adesh Raghavan, who is an endocrine surgeon in Belroth, Aripuram, he only sent the case. I'm just including his name for the next slide. Next slide. Next slide, Bala. So the patient, 62-year-old female, presented with pain abdomen and found to have a cyst in the retroperitoneum, and while evaluating for a left-sided pyelonephritis. She came for some other complaints, and incidentally, the PET CT was done, and the image was given here. Next slide. Next. Yeah, the FDG PET CT study of the whole body was done. The impression was given, and it was found that large, fairly well-defined, non-metabolically active, predominantly hyperdense lesion with septations, slightly lobulated margins, multiple calcifications, and poorly enhanced minimal solid areas in the region of the left suprarenal region. And the left adrenal was not separately visualized during the PET CT, and the impression was concluded as likely benign, possibility of underlying adrenal neoplasm, bar giant adrenal adenoma with hemorrhagic degeneration and calcifications, suggested HPF correlation for confirmation. Next slide. Before that, the CT-FTG report, they have some criteria in the European and American Society of the Endocrinologists, and it could be benign category and non-functioning. Depending on the CT picture, they can call it as benign, and if intermediate type of cases are found in the CT, we have to search for adrenocortical carcinoma and pheochromocytoma and other conditions. So, Dr. Adish was little apprehended about the surgery. The adrenal tumors could have been the cause in this patient. So he was very careful and while doing the surgery, and there was an addition between the stomach and the posterior aspect of the stomach and then the superior aspect of the pancreas. So he carefully removed all the additions and took the mass in toto. And during the surgery, the ballotability was done and her BP was under control. So he went again with the surgery and it removed. The post-operative diagnosis, what he sent with along with the request, is an adrenal incidentaloma. Next slide. The gross, what we received, a cyst, soft tissue measuring 8 into 7 into 4. The cut surface, very thin vascularized capsule and few solid mucoid material overlaying pale yellowish white cheesy material with hemorrhagic areas. So from the gross, we could not come to any conclusion. Then we went ahead, we took enough bed from the capsule because the mass was, when we did this grossing, it was just coming off from the capsule. It was not attached to the capsule in any of the places, and we were able to take the capsule separately and then the mass. So the following comes as a histopathology picture. Next. Yeah, this was the microscopic images showing a pseudo-stratified ciliated epithelium with a collection of inflammatory cells. Next slide. I'll just go through all the slides. This one slide showing a tiny island of a cartilage beneath the pseudo-respiratory ciliated epithelium. Next slide. Yeah, this is another enclosing a mucus gland. This one with the cystic spaces filled with cyst macrophages and a mucoid material. Next. This is a multiple cystic spaces filled with mucoid material, and then the lining is again a stratified ciliated epithelium. Next. This is another space, and here the stroma was filled with more of a lymphocytes were there. Next. This is the area, the proteinaceous background, the calcification was seen. Numerous calcification, plenty of areas were showing this proteinaceous material and the calcification. Next. So I was really breaking my head to come to a conclusion. Next slide. Next. So the microscopic description shows a cyst lined by pseudostratified ciliated columnar epithelial cells and subepithelial tiny strip of cartilage and multiloculated cystic spaces by thin mucoid material, cyst macro. Whatever I showed you in the picture, this is condensed in the description. Next slide. Next slide. So I didn't know what I am going in. No, ma. Previous one. Yeah. Next. So the differential diagnosis, considering the retroperitoneal benign cystic teratoma extragonadal and diaphragmatic and gastric duplication cysts and adrenal cyst pseudotumors such as splenic loculations and gastric diverticulum, renal, pancreatic or hepatic masses and periadrenal varices were all that. Though it was all grouped under the incidentaloma, I thought all this to be eliminated one by one. Then we have to come to a definite conclusion. Next slide. So then, considering when I went through the literature and the references, the presence of this the bronchial epithelial cells predominantly with the cyst macrophages and hemorrhage calcification in the retroperitoneal region, the possibility of a retroperitoneal bronchogenic cyst on the left side, which was more commonly seen in the literature. Do cases occur in the right side, but ours fit in with the common entities, common presentation. So I suggested IHC markers CK7, CK20 and TTF1 for a confirmation. With correlating with PET CT and clinical picture, follow-up was suggested to the surgeon. Next slide. The immunohistochemistry report came as the TTF1 and CK7 was positive in the pseudostratified lining epithelium in all the cystic spaces and the cuboidal cells, and CK20 was negative. Before that, the patient was asymptomatic and she was investigated only for a left-sided pyelonephritis, and the lesion was found in the retroperitoneum and a non-functioning tumor according to the surgeon's report. So we went ahead and delineated the points favoring our diagnosis. Next slide, ma. Yeah, this highlighting points for the differential diagnosis. The differentiating teratoma from a retroperitoneal bronchogenic cyst, which was thought to be a common diagnostic dilemma, using an IHC marker can be very tricky. But what we have is a quick breakdown. The teratoma is usually positive for markers like SAL4 and OCT4 SOX2, indicating a pluripotency, may have various tissue elements. That is CK20 also, and in the gut-like areas will be present. But in our case, typically it is positive for CK7 and TTF1, adenosine A, might express CK20 if enteric epithelium was found in the cystic spaces. Next slide. So the key difference, teratoma often shows a mixture of tissue, ectoderm, endoderm, mesoderm, and pluripotent marker, while bronchogenic cysts are more lineage specific, respiratory epithelium or enteric epithelium. We need more specific markers or dealing with the specific case according to our presentation. Next. So when we delve into the embryology, the possibility how the bronchogenic cyst comes into the retroperitoneal space. There are evidence to show they arise from the foregut as malformation when normal bronchial tubes are developmentally separate. That is within the foregut, that is within the thorax and the mediastinum. That is during the very early embryonic life. If it crosses the 20 weeks of presentation, the gestation, it will be different. And early embryonic life, the pericardioperitoneal canal, which links the thoracic and abdominal cavity, it is obliterated by the pleuroperitoneal membrane as part of tracheobronchial tree get pinched off and migrate, resulting into the plumule, that is abdominal gut, and the development of the bronchogenic cyst. Next slide. So, before going into the discussion, the retroperitoneal bronchogenic cysts are very rare and 0.03% of the tumor cases. They originate from the embryonic foregut and development from the section of this abnormally formed trachea and bronchial reed that occurs during the early stages after the detachment and implantation of the plumule into the abdominal cavity. So going by the discussion with all these features in mind on the slide with the IHC marker, I went into this discussion. They are benign cystic congenital aberrations caused by the abnormal budding of the tree between 26 and 40 days of embryogenesis. They are primitive Foger-derived anomalies of the bronchial type, and they are usually discovered in the thorax and mediastinum. Next. The occurrence of such cysts is very rare, and rarely they are localized on the left adrenal region or superior body of the pancreas, and imaging techniques are generally effective in the detection of the retroperitoneal bronchogenic cysts. Next slide. And one more thing, there are cases reported on the right side of the peritoneum, which is a very more rarer than the left-sided region. And in our case, the left adrenal was not present during the surgery, and there was no adrenal tissue was found in our sections multiple sections done in our cyst or the cystic lesion. So I just want to bring out the associated lesions with retroperitoneal bronchogenic cyst way back to 2002. Adenocarcinoma may arise in RBC, and 2004, some of them have reported in the inferior surface of the liver, mimicking as a gallbladder tumor. And 2020, the RBCs are in the lesser sac with neuroendocrine tumor, along with hydatid cyst in these cases. Next slide. Next slide. So the take-home message, the retroperitoneal bronchogenic cysts are often incidentally detected because of its unusual location. They are asymptomatic and benign, and rarely pressure symptoms may occur. Accurate preoperative diagnosis remains difficult. Only histology can prove a definite diagnosis, and often detected by a cyst by imaging modalities, USG, MRI, and PET-CT. As it was done in our case, PET-CT he did because of the mass in the abdomen and pain in the abdomen. It should be always kept in mind as a differential diagnosis for any retroperitoneal cyst. Next slide. So, next slide. Before that, previous one. The previous one. Hello? Yeah, the take-home message I just wanted to say, it should be kept in a differential diagnosis in cases of, and many more documentation of such cases will try to improve the diagnostic accuracy preoperatively in future. Unless we documented the cases, it will not be able to come as a part of the differential diagnosis in our mind. Next. So I just took some of the references. Next slide. From the bronchogenesis from the way back in 1857, the first case was reported, and after that, many have been done from the year 2000, 2012, 14, 16, 18, and 22, and then recently it was reported in the 2024 by a case report and literature review in the journal Frontiers of Oncology. So that finishes my case. Thank you all for the patient listening. Any questions from the audience?
Ma'am, was the patient symptomatic, ma'am?
No, the pain was there. 62 years till the younger age, she never had any problem.
Can we equate this to the monodermal teratoma?
One more thing, she had an intact uterus and tubes and ovaries, which are very normal. And only fibroid was removed during her in the age of 30 or something, it was removed.
Can we equate this to monodermal teratoma? Because you found cartilage, you found the other things, fat was there. And
carcinoid, generally we see the thyroid tissue or a carcinoid as a monodermal. We have never seen a respiratory epithelium as a single epithelial differentiation, a single differentiation, isn't it? With the see,
Retroperitoneal
cyst content was more of fluid, mucus, and a proteinaceous material, which giving rise to that calcification. For a long time, she may be having from how many years back, we do not know. So the left adrenal was not there, which was a typical presentation in the literature and as well as in our case. Instead of the left adrenal, the patient, this mass was fitting into the behind the stomach and above the pancreas, and he was able to remove it in toto. Yes, Sita?
No, I just wanted to know whether it can equal to a monodermal teratoma. That's all. Because, see, a monodermal teratoma is the one in which you find only one kind of the embryological derivatives. See, we have, as you said, you have 3 germ cell layers, and one of them can be responsible for the monodermal teratoma. So, since it is representing only the predominantly the mesodermal component, so I thought whether it could equate to be a monodermal teratoma, because your differential diagnosis included a retroperitoneal teratoma.
Yeah, that's a common in the retroperitoneum, extraconadal. But it is very, the other elements are not there, and the presentation was a different location. The location of the thing, I think the retroperitoneal bronchogenic cyst, the
I know.
folded.
I am not controversing your diagnosis of bronchogenic cyst. I just want that it can equate a monodermal teratoma. That's all. Okay.
No, but the entry and other components are not there, no? The squamous epithelium, hair, gross is not fitting with. Gross is totally a different one. Like if it is a monodermal teratoma, it will be little more liquefied material, and then the other components will be there now.
Okay.
Literature confirms the retroperitoneal bronchogenic cyst is a more fitting diagnosis rather than the other.
Madam, why it is called incidentoloma? What is the definition for incidentoloma?
Because it was found out during the CD of the CT, PET CT for some other cause, sir. The patient has not come for the mass or anything. It was not identified before. Only during the PET CT the mass was found, and then the surgeon with he had a point of adrenal tumors only.
But it is a bigger one, no, madam. It's a big one.
Pardon,
it is a big mass.
18 to 10 centimeter.
Then how can it called as incidentoloma? I don't know.
It can be, sir. It can be. All the incidentallomas, all the pseudotumors of the adrenal region can present like a mass in the retroperitoneum with the same size. It can be vary from 2 to 12 centimeter according to the literature. And any mass of varying sizes will be there. And CT is more evidence, and then of course we have to correlate with clinical, histopathological, immunohistochemistry and radiological findings to confirm this case. Not a preoperative diagnosis was not anywhere near the retroperitoneal bronchogenic. He never thought of it. He was surprised actually, the endocrine surgeon. So I just wanted to bring out the diagnosis. Why I'm saying presenting case is to highlight the take-home message for if you come across any retroperitoneal mass or a cyst, you have to think this entity. When the mass is more towards an indeterminate type, according to the CT, we have to think the other possibility. As the surgeon thought of a pheochromocytoma, and adrenal cortical carcinoma, adrenal adenomas were thought in his mind, which was not there in our case. Okay, am I clear?
Ma'am, yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you so much for the presentation, and thank you for your enthusiasm. Thank you, ma'am.
Because of you, I'm growing, because of you all.
Thank you, ma'am. Thank you.
Bye, everyone.
Bye, ma'am. Bye, ma'am.
So
yes, ma'am. Can we go on to the next case, Dr. Angelin from Stanley?
Sure.
Yeah, it's all kind of nice.
Good afternoon, ma'am and sir. I'm Dr. Angeline from Assistant Professor from Government Stanley Medical College. Ma'am, I would like to thank my HOD ma'am and professors for giving me this opportunity. Coming to case, 63 years male with complaints of right inguinal-scrotal swelling, which was gradually increasing in size.
Excuse me,
investigating-
your slide is not moving. Your slide is not moving.
Ma'am, is it visible now, ma'am? Second slide.
Yeah, the first slide is not there. I can see it in the margin, some of your X-ray findings, but that is not been highlighted. And history also you said, but it is not shown in the screen.
Next slide, please. Stop share entire screen. Entire screen.
Now it is seen.
Okay, thank you, ma'am. Ma'am, 63 years male, complaints of right inguinoscrotal swelling. The swelling was gradual increasing in size, and the CT abdomen it showed a well-enhanced heterogeneous lesion in the inguinal region. So, with central necrosis. So, preoperatively, the diagnosis were chronic orchitis with Cori right inguinal hernia, and they proceeded with surgery. The intraoperative findings were there was a mass along the cord in the right inguinal region measuring 6 cross 5 centimeter. So they done the dissection along with testes, and after the surgery, the postoperative diagnosis was lipomatous lesion of right spermatic cord with orchitis. The patient is also known case of astrocytoma but the clinical details are not being available. So we received the right orchidectomy specimen with excised paratesticular mass. This is the external surface showing lobular gray tan fibrofatty tissue with testes, and the cut surface shows the normal testicular parenchyma made out, and there is a fibrofatty, there is a multilobular swelling in the adjacent fibrofatty tissues noted. Cut surface shows a gray white to gray yellow firm to fleshy soft tissue mass with adjacent gray yellow areas. This is a microscopic picture. The scanner in the scanner view, the testicular parenchyma is made out with seminiferous tubules of varying size, some of them showing maturation arrest, and the adjacent neoplasm fibrofatty tissue consisting of neoplasm with consisting of lobules of adipocytes of various sizes with an adjacent neoplasm consisting of sheets and interlacing fascicles of smooth clear or spindle-shaped cells. This picture shows the abrupt transition from lobules of adipocytes to the adjacent neoplasm. The neoplastic cells are spindle-shaped with oval enlarged nuclei and some with prominent nucleoli. The mitotic activity is seen around about 4 to 5 per 10 hyperfield. With this, we consider the following diagnosis as dedifferentiated liposarcoma, and with the morphology of the cells, we also considered leiomyosarcoma as the differential diagnosis. Then we proceeded with immunohistochemistry markers, which showed diffuse positivity for MDM2 marker with focal positivity for Desmin. After this, we have signed out as paratesticular mass, which is of dedifferentiated liposarcoma, grade 2, FNSC, LCC grade. So, coming to discussion, the paratesticular tumors are rare, usually encountered around 5% of the intrascrotal masses, of which 70% are benign and 30% are malignant. Usually, they are asymptomatic, but sometimes it may be potentially life-threatening. The most common site includes the spermatic cord, and the least is the epidermis. The common tumors include the benign and the malignant. The benign tumors are lipoma, leiomyoma, adenomatoid tumor, and these are some of the tumors. Among the malignant tumors, liposarcoma is the most common. Then is the leiomyosarcoma. So the criteria for essential criteria for diagnosis is abrupt or gradual transition from well-differentiated liposarcoma to spindle or pleomorphic non-lipogenic component. That is, we saw in our case, and the desired criteria may be positive for MDM2 marker and measure MDM2 gene amplification. So this is the article which shows that paratesticular soft tissue sarcomas are very rare. That is 0.3 cases per million, and among that the most common is liposarcoma. And this liposarcoma should be identified clinically because in case of well-differentiated sarcoma, if it is identified, it is okay. But if it is in delay in identifying diagnosis, it may lead to the aggressive, that is high-grade liposarcoma. So why this is important? Because the diagnosis of paratesticular tumors remains dilemma and clinically challenging because they may mimic the tumor arising from testis or the inguinal region, which can either be benign or malignant. So in these cases, if the surgery is being delayed or unidentified, the patient may have a distant metastasis later. So incidentally, recently we also received a case with who is 65 years male with complaints of swelling right side scrotum noticed since 1 month, and the USG shows likely malignant right epidermal mass with mild hydrocele, and the CT shows a malignant lesion in the right scrotum, likely epidermal origin. So excised right testis with mass along the cord. So we received the testis along with cord, and there is a tumor arising from the epidermis. The cut surface shows a gray yellow and a focal gray hemorrhagic and necrotic area, yellowish areas. So this is the scanner view showing the tumor arising from the epidermis. The cells are spindle shaped with enlarged pleomorphic nuclei, and here the mitosis rate is increased. That is approximately 16 to 18 per 10 hyperfill, and mitosis and area of necrosis also seen. So with these morphological features, we signed it out as leiomyosarcoma. So great.
to come.
Grade 2. So IHC has been under study. Some paratesticular tumors should be identified clinically, even if a patient has little symptoms, or there may be distant metastasis, or if the tumor has been resected without the negative tumor margin, there will be a local recurrence in case of these tumors.
Thank you.
Thank you.
Yes, the case for discussion, ma'am. This case is presented for its rarity, dedifferentiated liposarcoma of the spermatic cord. And incidentally, in the same month, we had another paratesticular mass supposed to be a leiomyosarcoma. IHC yet to come. IHC markers are yet to come. Just wanted to present the case just because there was two paratesticular masses in the same month. Any questions, ma'am?
No questions actually, it was nicely presented.
Okay, ma'am. So the case was presented only for its rarity, ma'am. That's
Yes.
all. Okay, ma'am. So can we go on to the next present?
Epididymis, it goes near the infiltration into the epididymis.
No, in the first case, no infiltration, ma'am. Epidermis was full of congestion only, ma'am.
Okay.
Epidermis and cord also was free of tumor infiltration.
Okay. Okay, generally we have to look for in some of the cases. That is why
Yes, ma'am. The resected ends are free only, ma'am.
Thank you, ma'am.
Thank you. Thank you, Dr. Angeline. Can we go on to the next presenter, Dr. Pavitra from Apollo Hospital? Dr. Pavitra? Dr. Pavitra, are you there? Can you share your screen, please?
Hello, ma'am.
Yes, ma.
Yes, ma'am. Am I unable to share my screen, ma'am?
You call me. Dr. Pavitra? I can share screen. Close ಮಾಡಿರಲ್ಲ ಅದೇ ಆವಾಗ ಮುಂಚಿದಕ್ಕದ ಹಿಂಗೆ ಉತ್ತರನಿ ನಾನು ಹಂಗಂದು ಯಾರಿಗೆ ನೋಟ್ மட்டும் வாங்கிக்கோ tabs on the left over here.
Ma'am?
Yes, ma. Yes, Dr. Pavitra, please.
Yes, ma'am. I'm trying to share my screen, ma'am. 1 minute.
வந்துச்சுல நம்பல
Screen sharing only.
இவங்க பிரச்சனை பண்றாங்க
Their screen. Screen.
Can we do something?
Laptop will be slow.
Pavitra, உங்க screen share ஆகுது.
Okay, ma'am.
Yes.
Your screen
Yeah,
is in front.
Pavitra, you can start.
Yes, ma'am. Good afternoon, everyone. I'm Dr. Pavitra from Apollo Hospitals, Chennai. I'm going to present a case where there's a radiological and pathological paradox when appearances mislead. So, it was a 61 years old male who's working as a farmer, presented with complaints of seizure and abnormal movements of all the forelimbs, and the patient had loss of consciousness. He's a known case of hypertension as well as diabetes mellitus. The clinical suspicion was whether it could be a glioblastoma versus tuberculosis. So the radiological imaging findings, here we can see there's an ill-defined lobulated intraaxial space-occupying lesion in the posterior parasagittal, parietal and occipital lobe, measuring approximately 3.2 centimeter in greatest time, 3.2 into 3.4 into 3.8 centimeter. Then, this is the diffuse weighted imaging sequence in which we are seeing a central restricted diffusion and with a low ADC value. And on the post-contrast T1 fat saturation, we are seeing there's a shaggy nodular peripheral enhancement. So the radiological diagnosis was, it was a high-grade glioma. It could be a glioblastoma, possibly a grade 4 favoring IDH wild type, or else the differential diagnosis which they provided was lymphoma. And then the patient was taken to the OT and a frozen section. A patient was posted for surgery and tissue was sent for frozen section. So in the squash preparation, we were seeing some granulomatous inflammation, granulomatous lesion. And on going to a higher power, we were seeing septed pigmented fungi. And when the specimen came for a permanent section, we were able to see these septed hyphae along with some globose, like the globose swelling is seen in few areas. The PA has also highlighted the fungal hyphae as well as the spores. GMS also highlighted the fungal hyphae. And we put Mason Fontana because these were the pigmented fungi. That's why we were seeing these brown color, yellow, brown pigmentation in the cell wall. So Mason Fontana stain also was positive fungi in the diagnosis of Phaehypomycosis culture also, and it turned out to be Cladophyllophora bantiana. So this is the Severus dextrous agar in which they grow, and it came out to form a olivaceous greenish gray to blackish growth. And then lactophenol cotton blue stain was made, which showed a smooth-walled olivaceous cohesive string-like appearance, in following which Maltitov was done and the speciation of Bantiana was made. So the culture report was Cladophyllophora bantiana. Initially, the patient was treated with voriconazole, but after a follow-up, MRI was made after a period of 1 month, and there was still an increase in size, and hence a near total excision of the lesion was made. And the patient is now presently on amphotericin IV. So these Phaehypomycosis is a group of demeticious fungi, means they are pigmented dark-walled fungi, and they are known to cause cutaneous and subcutaneous disease, brain abscess, as well as sinusitis. Though it is commonly, they are telling it can happen in immunocompromised as well as in immunocompetent host. Recent evidence suggests that the CARD9 deficiency people like caspase recruitment domain family member 9, when they have a deficiency of this, they lose their ability to mount an immune response against a fungi, and they are more prone to such an infection. If the patient has a brain abscess, he might have headache, low grade to no fever, focal neurological symptoms, as our patient had even seizures. The entry point of the fungal, it still remains unknown. They don't know how it is invading the host, because few of them present with sinusitis as well as pulmonary focal lesion, focal infection, but many don't present with those, directly a brain abscess. And coming to the literature, many of the patients were male, around a category of 30 to 60 years of age. And as I told earlier, even immunocompetent patient get this fungal infection, which is highly invasive and present with brain abscess. Though voriconazole is the treatment of choice, now recently many case reports are stating that amphotericin B is giving much more higher response compared to voriconazole, and the mortality rate is very high. The few studies even quoting it up to 77%. So this is a rare diagnosis in which the radiology showed a neoplastic high-grade glioma, while when it came to us, it turned out to be a fungal infection. Thank you.
Thank you, Dr. Pavitra. Questions? Any on the case for discussion?
I'm Dr. Jamila from Medical College.
Yes, ma'am.
I just want to know.
Madam, echo ஆகுது நீங்க பேசுறது.
I just want to know whether do you routinely do fungal culture?
இல்ல madam, your
Ma'am, it's echoing, ma'am.
Any questions, please? So that was how commonly you're seeing such cases, Dr. Pavitra?
No, ma'am. I have seen this for the first time. I'm a fresher.
I'm
just
Dr. I will. It is very, very rare, actually. We have seen only. This is the second case or something after all these years. So this is. It's a very, very rare infection.
So it was an infection masquerading as malignancy, but that was
exactly. It presents, actually the patient, they were suspecting whether it's a glioblastoma or because of his infection, he had some symptoms of infection and weight loss, so they thought it could be tuberculosis also. They never thought of this fungal infection.
So the patient had weight loss and all?
Yeah.
Respiratory infection, no respiratory infection?
No, ma'am, no.
Swimming pool, they were seen go for a swimming or any history?
Don't really know, ma'am.
Ma'am, our farmer, madam.
Oh, farmer. Farmer na almost kolankottaiyila vizhundu ezhundiruppaanga.
Shiva, fungal infections of the brain are not uncommon, but this particular fungus is, of course, very, very rare.
This Phaehypomycosis is very, very rare.
Yeah.
So fungal infection, other fungal infections we have seen. I am talking about this pigmented fungi, diatomaceous fungi. Phaehypomycosis is very, very rare. It's just caused by
but that is mainly a cutaneous.
Skin we have seen like that.
Exactly. That is true. That's right. Okay, it's a rare case, agreed.
Could be angio-invasion nature of the fungus is common. Angio-invasion.
It was not angio-invasive. There were granulomas, and most of these fungi were within the giant cells.
Oh,
but it was extensive.
Phagocytic activity.
Yes.
But these infections are opportunistic infections, Shiva.
Yeah, possible, but these can also occur in immunocompetent patients. That's why it's very scary. Usually, we see opportunistic in immunocompromised people. So, this can occur in immunocompetent people also. So, that is the thing. And
How is the patient doing with treatment?
yeah, actually, the patient had another surgery also, like two times. First, how we diagnosed, then again he went home and became worse, and then again they removed some part of his brain. Still, he has not recovered fully, but he's been treated.
But very expensive, no? Amphotericin B.
Yes, ma'am.
50,000 BD injection have to be given.
Ma'am, even ICU charges for all these days also, that also.
Yes. No, leave alone that the medicine itself very costly and extended treatment to be given.
Yes, ma'am.
Thank you, thank you.
Okay, thank you, doctor.
Yeah, I thought it was a very rare case and interesting, and to present for all of us to know about this pigmented fungus.
Yeah, thank you, Dr. Pavitra, and thank you, Sheba, for that rare case. Thank you.
For the
so much.
opportunity.
So can we go on to the next presenter, Dr. Kirti? Dr. Kirti is ready?
Yes, ma'am. Yes, ma'am. Ready, ma'am.
Please share your screen.
In the mood of it.
Dirty water, clean water. Dr. Kirti? You can go to the slideshow mode and you can start. Please start, ma. Unmute. She's muted. She's talking. But unmute. Dr. Kirti, unmute yourself. We can't hear you. Unmute பண்ணுங்க. மியூட்ல தான் இருக்கீங்க நீங்க. நம்ம பண்ணோம். சாப்பிட்டியா? சொல்ல வேலை. அது டீ குடிக்க மாட்டியா நீ கூட?
Is it audible now, ma'am?
ஏன் உனக்கு குடுக்கல? அப்புறமா குடிச்சிக்கிறேன்.
Am I audible, ma'am?
Yes, ma.
Okay. So, good afternoon, everyone. Myself, Dr. Kirti here, a senior resident from Lalitamige Medical College. And I would like to express my sincere thanks to our respected HOD, Dr. Lalita ma'am, and our professors, Dr. Rama ma'am, Papati ma'am, Sumitra ma'am, and Sureka ma'am, all our department colleagues. And I also extend heartfelt thanks to City Pathology team to providing me this opportunity to present the case. So, we'll go to the case. So moving on to the contents, first I'll be discussing about the case presentation. Next, the gross features of the case, and moving on to microscopic findings, and finally the diagnosis, a little bit about the case discussion. So the clinical history which was provided was a 50-year-old female who came with a complaint of thyroid swelling for about 8 months, which was gradually increased in size. No change in voice or obstructive symptoms were found in the patient. So by clinical examination, there was an enlarged thyroid gland bilaterally, shows nodularity, and no palpable lymph nodes found. So radiology wise, they have given us a TIRADS 2 where the bilateral thyroid gland shows multiple nodules of varying sizes. No coarse calcification or cystic changes have been observed. So then the patient underwent the FNAC, the bilateral lobe, where the smear shows a cellular and the sheets of thyroid follicular cells are arranged, whereas this macrophages, thin and thick colloid background with no atypia in the cells have been observed. So this is the microscopical image where we can see the thyroid follicular cells, which is arranged in sheets, and there is minute anisonucleosis. Otherwise, there is no atypical features. And there were areas showing a thick colloid and also cyst macrophages along with thin colloid areas. So with all these features and radiological view, we gave as a Bethesda category 2 according to our latest edition of follicular nodular disease. So then the patient was undertaken the surgery and the specimen was sent to histopathology department. So this is the gross features where we received a total thyroidectomy specimen. Bilateral lobe appears to be enlarged and outer surface appears to be a little irregular, where it's showing multiple nodularity, and there is no capsule breach or something is seen. So next, coming to the cut surface, where bilateral lobe shows a multiple nodules of varying sizes filled with colloid, and also the foci of grayish white area which were observed in right lobe. Especially, these are all the multiple colloid nodules, whereas the yellow circle indicates that grayish white area which has a gritty, while we are cutting the section we have seen, which is in the right lobe upper region. It's approximately 9 mm in diameter, and it is away from the capsule. So next, moving on to the microscopic images, this is the low power view where we can see multiple colloid-filled follicles which is arranged in nodular pattern. So here are a few areas where we can see the dominant nodule surrounded by the fibrous rim, and the follicles are lined by thyroid follicular epithelial cells exhibiting bland uniform nuclei. So here comes the suspicious area, where in the low power only we are saying there is a reveals a nodular lesion with focal calcification we see here, and along with the atypical cells which is entrapped within this calcification. So on the higher magnification we can see the nuclear features. So here we had a doubt. So grossly and radiologically, it seems to be multinodular goiter, but microscopically we had few suspicious area. So there we have did extensive sampling by exhausting the specimen mostly, and we have given a resection where we found a nodular area where the non-encapsulated, it's like well-defined, but it is not encapsulated nodule which composed of a tumor cells. The second image shows you where the tumor cells are predominantly arranged in follicular pattern. And the third image, we can see there are nuclear features where the red arrow indicates there is an optically clear nuclei which looks like a of an anneal. And here the yellow circle indicates the nuclear grooving which looks like a coffee bean. So these are the findings which we have observed. Nuclear clearing was there, grooves was there, overlapping, and occasional tiny pseudo-inclusions were seen. So, and also the areas of calcification were also observed, and the margins are free from the tumor. So the mitotic rate is less than 3 per 2 mm square, and there is no tumor necrosis, angioinvasion, LVI, and perineural invasion was not identified. Regional lymph nodes have been not submitted. So then we had performed the IHC in the suspicious area. So here are three images where the first image I told us a dominant nodule which we have observed, and we didn't perform any IHC in this. Where the second area which we had a little suspicious area, we performed IHC, but unfortunately it turned out to be due to calcification, the sections didn't come out that well. So where the third image shows you the resection which we had given, we perform IHC in this image. So where we can see the results very clearly, the CK19 shows in the resection slide, even at the scanner view, it shows a red flag. So here, the tumor cells exhibit the characteristic of a diffuse strong cytoplasmic membranous positivity. In the higher magnification view, we can clearly appreciate it. Whereas in CD56, it shows to be negative in that particular tumor area, and CK56 is negative, CD56 is negative, and CK19 seems to be positive. So with all this, clinically it's a benign, whereas radiologically it's a multinodular goiter, but histologically it turned out to be malignant, where a millimeter-sized carcinoma hiding in a multinodular crowd. So here we also consider our differential diagnosis as NAFTP, but almost we have exhausted the specimen where we didn't find any other areas in our case especially, and also it's a non-encapsulated tumor with follicular pattern and clearly having papillary nuclear features. We gave as a diagnosis of incidental papillary microcarcinoma considering the size of the specimen tumor size that is less than 10 mm, and also a follicular subtype due to the pattern, multifocal because we identified in two areas where one is 9 mm which is seen grossly while the other one is not picked up by cross. We have seen only in the microscopic image. In a follicular nodular disease background. So here the MNG turns out to be microcarcinoma, and the staging was given according to latest CAP protocol PT1A, NX and MX. So according to AJCC 8th edition. So whereas I want to highlight the points in CAP latest edition, all papillary microcarcinoma which is less than or equal to 1 centimeter should be subtype based on 5th edition of WHO classification of thyroid tumors. Whereas the papillary carcinoma does not stand alone as a subtype, always we have to subtype the designation. So here a little bit about the BRAF. So the BRAF pathway tells us how the cell grow, divide and survive. It is really important in papillary carcinoma of thyroid. What really happens? The growth factor will bind to the cell membrane. So this receptor is usually a tyrosine kinase receptor where it becomes phosphorylated. So here the switch is on. The signal transduction begins here. The RAS will get activated and brings up a molecular switch, and that converts the GDP to GDP. So then the BRAF gets activated, the serosine and threonine kinase further phosphorylates this MEK to ERK. And ultimately it enters to the nucleus, and finally it leads to uncontrolled tumor proliferation which results in tumor. So this is the basic BRAF pathway we should know in thyroid cancer, especially in papillary thyroid. So in microcarcinoma also the BRAF pathway is very important because few of the articles shows that the microcarcinoma follow-up cases have turned out to be papillary thyroid carcinoma as a solitary nodule. So why BRAF is so important in tumors? Because it's not just a mutation. It is like a conductor of the tumor orchestra where it's driving the proliferation, invasion, altering the differentiation, and also even shaping how the tumors to be respond to the treatment. So what is the clinical significance here? It serves as a prognostic marker, predicts the radioiodine resistance, and also used for targeted therapy. So these are the few articles which we have referred during this case and what we have learned from this article. So according to CAP, the WHO definition is a tumor which is less than 1 centimeter in diameter is considered to be microcarcinoma. And other points which we have read from the article is the incidence of a papillary microcarcinoma is less than 30% of all papillary thyroid carcinoma. And how far is the incidence in multinodular goiter? It is 7 to 17% of papillary microcarcinoma. And how far is the multifocality? It is 20 to 46% in cases. And incidence of lymph node metastasis turned out to be 13.7. And most of them are here incidental diagnosis, whereas in autopsy or MNG, which comes for thyroid specimen, something like that. And the negative FNAC ultimately doesn't rule out a microcarcinoma, even if it is USG guided. The close follow-up is very much essential for multinodular goiter and also the follicular nodular disease. So what are the takeaway points here? So if we had sampled only the dominant nodules, this diagnosis would have been missed forever. So as I always remember, when I was as a PG, my professor, Dr. Ramdas Nayak, used to say, you PGs are the one who brings us the slide to us, who will give the diagnosis. So it's always that much important what the PG show, the professor's diagnosis is really matters. So as a PG, we should gross meticulously to avoid all this misdiagnosis. So the microcarcinoma is often grossly invisible and it can be easily missed on routine sampling. The generous sampling of dominant and non-dominant nodules are necessary. So usually present as incidental diagnosis. And the papillary thyroid microcarcinoma is a silent passenger in multinodular goiter. Only a meticulous grossing and adequate sampling reveal its presence. So don't let the nodule fool you. The grossing is our best tool as a pathologist. So these are my references. Thank you, ma'am.
That was a very beautiful presentation, Dr. Kirti. And
Thank you, ma'am. Thank you.
your animations,
it
everything. So
was an
nice.
eye opener. It was an eye opener for a proper grossing in thyroid.
Yeah,
We always
so-
insist the thyroid sections to be taken properly, and every nook and corner of the thyroid has to be seen, even if you find a very small whitish nodule. We always tell the postgraduates that. And secondly,
Yes,
when
ma'am.
when clinically they suspected only a benign lesion, and when you report a microcarcinoma, it is very, very essential that they have a very close follow-up, and also neck nodes have to be evaluated. So that is a
Yes,
very,
ma'am.
very
Definitely.
important point to remember. Okay.
Yes, ma'am.
yes, Doctor.
Thank you.
Dr. Kirti, that was stressing the importance of grossing, and there is increased incidence of papillary microcarcinomas being reported as of now.
Yes, ma'am. Definitely. So it's mainly to highlight the grossing importance, especially to PGs. So we have brought this case, ma'am.
Okay, thank you so much for that. And can we go on to the next presenter?
Thank you, ma'am.
Dr. Wimsey from KMC.
Yes, ma'am.
Dr. Vinci, please.
Yes, ma'am.
Yeah.
Shall I present, ma'am?
Yeah, Ninga present Pandanga. Welcome.
Yes.
You
Thank
have to
you, ma'am.
go light show mode.
I thank
Dr.
my
Vinci,
beloved
please,
HOD
please.
for giving. Am I audible, ma'am?
Yes, yes. Ninga start Pandanga. Time ad.
I thank my beloved HOD for giving me this opportunity to present in this forum. I'm here to present a 51 years old female who came with complaint of abnormal uterine bleeding. She is a known case of type 2 diabetes and hypothyroidism. She was diagnosed with fibroid uterus. Her MRI showed submucosal fibroid in the anterior wall and the posterior wall. In the uterine fundus, there was an exophytic broad-based non-pedunculated fibroid lesion measuring 13 cross 11 centimeter in the anterior wall. So the patient underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy. Grossly, we received the uterus with cervix measuring about 8 cross 7 cross 3 centimeter, and the uterus fundus showed a subserosal nodule measuring about 15 cross 11 cross 11 centimeter, and we could the subserosal nodule consisted of both solid and cystic areas. The solid area showed grey tan and grey brown material, whereas the cyst was filled with grey brown hemorrhagic material. Endometrial cavity was made out, and the myometrium also showed 2 more intramural nodules. When we proceeded with histopathological examination, the endometrium was atrophic, and in low part, in the myometrium, we could make out a benign neoplasm arranged in interlacing fascicles with bland spindle-shaped nuclei. And when we moved to the next area, we could make out that a wolf was unveiling its sheep's clothing. So here we can see a neoplasm infiltrating the fibroid, leiomyoma, and more areas where you can see the neoplasm is arranged predominantly as nest sheaths, tubules, and micropapillary area adjacent to the benign leiomyoma. On higher magnification, we could make out the cells were round to polygonal with moderate eosinophilic cytoplasm and pleomorphic hyperchromatic nuclei, with many of them showing vesicular nuclei with prominent nucleoli. So we were wondering, is this a primary uterine carcinoma? And our differentials were carcinosarcoma, where both the epithelial and mesenchymal component will be malignant. But in our case, the epithelial component was malignant, but the mesenchymal leiomyoma was bland or benign. Whereas the second differential was epithelioid leiomyosarcoma, where we could make out that the neoplasm was arranged predominantly as nest and tubules, whereas in epithelioid leioma, it will be more of sheaths. And the necrosis part was less evident in our case. We were wondering, was it a metastasis? So we moved on for IHC. Meanwhile, we had a suspicion from where the metastasis would have come. So when we did IHC, Desmond showed a strong cytoplasmic positivity in the leiomymatous cells. EMA was positive in the neoplastic epithelial component, malignant component, which is evident by the strong positivity in the tumor cells. We did PAX8, which was negative, which rules out carcinosarcoma, whereas CD10 was also negative, which also ruled out epithelioid leiomyosarcoma. ERPR was done. Both of them showed nuclear positivity in the tumor cells. Here too, it is evident that the neoplastic malignant component has taken up the HER2 staining, which is evident by the strong membranous positivity of the tumor cells. Ka67 was performed, where you can see the surrounding leiomyoma has not taken up the proliferative index, whereas the malignant neoplastic cells have taken up the proliferation. So we sought the help of GATA3, which clinched out the diagnosis. So it was strongly positive. And with this, we came to a diagnosis of metastatic carcinomatous deposits into the leiomyoma, probably from the breast. Meanwhile, we also got CD from the patient that she had underwent oncoplastic breast conservative surgery in 2022 for carcinoma breast, which was T2N1C. Coming to the discussion part, breast carcinoma usually spreads to bones, lungs, or liver. Metastasis of breast carcinoma to a uterine leiomyoma is comparatively rare, and we present this case for its rarity. Very few cases are reported in the literature. The mean time elapsing between the diagnosis of breast cancer metastasis to uterine leiomyoma for this patient was about 3 years, and the prognosis is comparatively poorer for this patient because she is upgraded to the stage 4. The main factor which plays an important role is the cytokines and the estrogen dependent hormone drive, which provides the tumor microenvironment for the metastasis of breast in the leiomyoma. So the take-home message is that a prompt morphology, IHC, clinico-radiological correlation, and wisdom is needed to arrive at a definite diagnosis. Even one of the puzzle is missed, we'll miss the diagnosis. Thank you for your patient listening, and these are my references. And I thank the HOD of Stanley Medical College for performing IHC. The GATA3 IHC was performed from Stanley Medical College. Thank you, ma'am.
Thank you, Dr. Vamsi. And was there any other metastasis in this patient? Vamsi, Dr. Vamsi?
Yes, ma'am. Be happy she has only one.
Was there any other, did they do a PET, and was there any other metastasis?
Any other site?
The patient had only breast metastasis was present in the leiomyoma. Cervix, fallopian tubes, and ovaries were all normal.
No, I meant any other site other than the uterus.
No, ma'am. No. The patient had lymph node metastasis at the time of diagnosis. So she was termed as T2N1C at the time of diagnosis in 2022.
Very, very rare. Never heard.
Did you look back in the literature? What is the incidence of CA breast metastasizing to leiomyoma?
It is very, very rare, ma'am. Worldwide, it is only 7 to 8 cases are presented.
Yeah.
And I could not get any reference from our literature, from our standard books.
Google பண்ணுங்க.
Thank you, Dr. Vamsi, and thank you, ma'am, for your inputs, and thank you for that rare presentation. Can we go on to the next presenter, Dr. Krishna Kumar, sir? Sir, KK, sir?
Yes, madam. Yes, madam.
Yes,
I'll try to.
அவர் வரேன்னு சொல்லியிருக்காரு. பேசுறதுக்கு நல்லா பேசுறேன் சார். ஷேர் பண்ணுங்க சார்.
Are you able to see, madam?
Yes, sir. Yes, sir. We can see, sir.
Madam, தெரியுதா madam? Madam,
Yes, sir.
தெரியுதுங்களா?
Yes, sir. தெரியுது, sir.
Madam, good evening to all the senior people.
Sir, உங்க
என்ன madam?
ரொம்ப
Hello?
உங்க பிபி yes, sir. Yes, sir. Slide show mode, sir.
Okay, madam. இப்ப பரவாயில்லைங்களா?
Yes, sir.
Good evening, friends. This was the case referred to the ocular surface clinic where the consultant saw a worm and they sent the worm to the pathology department. And myself and my colleague, Dr. Biswas, made a diagnosis of a Dedifferentiated repens. And some of the differential diagnosis, not possible, rare, like Theresia species and lower, we don't see much in our country unless until the patient is from outside. We see this sort of parasitic and Dedifferentiasis more from Kerala. The second case is a case from Dedifferentiated Hospital, Kerala, referred by Dr. Marian Polly. Lady, aged 52 years, had this face lesion and skin lesions for 7 years. Biopsy was done for a couple of times in Kerala and in Trivandrum, and diagnosis of tuberculosis and pyoderma gangliosum was made. She was an ATT, and she is on cyclosporine for past 4 to 5 years. And now the lesions are increasing, and she was referred to the Dedifferentiated Hospital because not only the skin lesions, you can see the lesions in the back, they are also on the face and going towards the eye ocular surface. So Dr. Marian Polly did biopsies, and she did biopsy from the skin lesions around in the margin and in the base. So 3 biopsies were sent. Because the patient was on cyclosporine for 4 to 5 years, the pattern was altered. However, we could see some sort of a necrotic areas and a lot of vacuolated cells suggestive of macrophages. Once again, you find the macrophages and the necrotic purulent area. No well-formed giant cells were seen. So with this, I gave a diagnosis. First diagnosis was it is a possibility and inflammatory infective etiology. So fungus is negative, pre-cellular tuberculosis, that's why I told. And in looking at the skin lesion, I also put a differential diagnosis of superficial granulomatous pyoderma. And if all the MTB is also negative, please do serum immunoelectrophoresis. And I gave this reference that superficial granulomatous pyoderma is a great mimicker. So why I thought this thing, I'll tell you. And the fungus was negative, bacteria negative, TB investigations was negative, and patient was ANA 3+, and patient was put on the cyclosporine was stopped, and patient was put on clarithromycin and steroids. Within 3 to 4 weeks, the lesion started decreasing, and then what happened? They started tapering the steroids, and once they started tapering the steroids, the lesions flared up, and the lesions, ulcers, and the things started expanding onto the face and towards the ocular surface, and the skin lesions also become slightly more florid. You can find these large blocks with crusting. This is the sieve-like pattern. And then on 15th, the lesions, the steroids were tapered, the lesions flared up, and there was a call from Kerala, what is it, what is happening? So then they also sent me fresh skin lesions. Now I shared these images and histopathology with Professor Yesudian and his son and Dr. Divakar at UK, and they see a lot of this. First thing is they agreed, the UK team agreed with the diagnosis of superficial granulomatous pyoderma, and they asked to put on intravenous immunoglobulin so that the lesions can be arrested. The patient was admitted into the Dedifferentiated Hospital, and she is on intravenous immunoglobulin. So this is very rare from Indian point of view. And superficial granulomatous pyoderma is rare. This is my second case. The first case I saw when I was a student at Kilpack Medical College, and Professor Patrick Azarian showed us one case, that sieve-like ulceration with pus coming. And this is very different from pyoderma gangrenosum, which is very acute, patient is sick. And usually the ulcers are very superficial. And so it must not be mistaken for a classic pyoderma gangrenosum. And this is from a textbook to show you how does the superficial granulomatous pyoderma can have. If the patient was not on cyclosporine, you could see the granuloma and necrosis. This could be mistaken for tuberculosis. So that's what this paper tells. It is a great mimicker. So we must have our thought process ready for this sort of diagnosis. So the patient is on IVIG, and I will update you next couple of 4 weeks. Thanks a lot, friends, for listening to this interesting case, and I would like to welcome comments from people.
Was any history of IBD, Crohn's, or lupus?
Yes, madam. Rheumatoid arthritis, lupus, serum stool call protectins, all are negative, madam. TB negative, fungus negative, ANA is 3+ positive, seen by rheumatologist, and now the dermatologist are with the diagnosis, they are looking into it. They have not seen much in preventum. I have seen only one case with Procedurian, but these sort of cases are common in the UK and in the Caucasian sins. So there is especially the facial type of superficial granulomatous pyoderma respond well to intravenous immunoglobulin. Patient is on steroids, and she is also on doxycycline as suggested by Procedurian. And intravenous immunoglobulins have been started on recommendation by the UK team. And fortunately, patient was able to afford. But this is something like an emergency. We have seen pemphigus, Burns, bullous pemphigoid, and Steven Johnson. Even this vague superficial granulomatous pyodermas, when it comes in the face and other areas with no proper diagnosis, at least we have a label. We can put on IVIG or steroids or dapsone and help the patient. So since it's such rare and it was very challenging, I would like to get comments from senior people.
Yeah, Krishna Kumar,
Yes,
your
ma'am.
ANA 3+ positivity, does it throw any light on any immune based?
Madam, I spoke the UK team, madam. They said at this stage they are not able to associate this ANA 3+ with the skin lesions. So they said, let us now start, put on IVIG. She's on steroids. Let us make sure we save the eyes now. Okay. So only in a couple of weeks I'll know, madam.
Okay.
First is to save the eyes of the patient now, and also the skin. We don't want the patient to lose the eyes. That's the reason, madam.
Okay.
Sir, thank you so much, sir, KK sir.
Yes, ma'am. Thank you, ma'am.
Also for those nice cases, and gone to the last presentation of this Dr. Lumilas. Dr. Lumila, please share your screen. Welcome. Good history is the cheapest specialty. Super. Samaya idriga.
Thank you, ma'am. Good afternoon, everyone. Am I audible and is my screen visible?
Yeah, you're audible and your screen is visible. You can start.
Crash. Hello, good afternoon to one and all. I'm Dr. Lumila, consultant pathologist from Aishwarya Hospitals, OMR. I know I am the one standing between you and your evening tea, so I'll be very crisp, I'll be very brief. I just want to talk about the importance of history in our day-to-day practice. So a good history is the chief.
Dr. Lumila, your PPT not moving. It's there stuck in the first slide.
Okay, a good history is the cheapest specialty. Now is it open?
Yeah. Yes. Continue.
So clinically, patient X, a 74-year-old female, presented with a 3x2 centimeter swelling in the right arm since 2 months. There was no complaint of pain, increase in size, or any restriction of movements. A radiology was done and it was diagnosed. It could be a probability of a benign ganglion cyst. But clinically, they were suspecting a soft tissue sarcoma. So intra-op, this was the image. There was a nice 3x2 lemon-sized lesion sitting in between the fibers of triceps, that is a lateral head of triceps. And this is the external surface of the lesion was quite smooth, focally nodular, bosselated a bit, but and the cut surface was fleshy to rubbery.
Now, coming to the microscopic slides, it's a fairly circumscribed lesion. You can see the muscle fibers here, that the lesion is entrapped within the muscle fibers. And you can see like these fat-like spaces intervening with, I think a better idea would be the next closer microscopic view. And here you can see these fat-like spaces intervene with these polygonal type cells. We went and had a closer look at the microscopic images, and we could see these again fat-like areas with few of the cells showing conspicuous to prominent nucleoli. We were very confused because clinically, radiologically, we were suspecting between a ganglion cyst or a very any benign lesion, and clinically they said maybe a low-grade sarcoma. And here we thought these were all like fat-like spaces intermixed with these polygonal-looking cells. So we're thinking along the lines of any dedifferentiated liposarcoma or any lipomatous tumor. And in the capsule, we could see this nice LVSI sitting within the vessels in this thrombus formation. And but still something seemed amiss. We were not very confident to give it as a dedifferentiated liposarcoma. I mean, we just saw a case of dedifferentiated liposarcoma, the paratestis, testicular lesion, and this is not how the picture looked like. So, I mean, we were very skeptical to go ahead with it. So we did the most important thing. We went back to our clinicians and we spoke to them and we asked them what exactly is the history and if there's any past history of any lesion elsewhere, what exactly was happening. And that's when they, came up with the story that the patient had a history of surgery and radiotherapy for a salivary gland carcinoma way back in 2009. Sorry. So that was about 16 to 17 years back. That's when it struck us that, these are all polygonal tumor cells and there are some of these cells, I'm not sure if you're able to appreciate in these images, but most of these cells have these very granular pinkish cytoplasm. So we went ahead and did the PAS and PASD stain, and those zymogen granules were stained by PAS and they were resistant to diastase, thus proving that this is an acinic cell carcinoma. We tried to retrace the reports, but we could not get hold of them. But all we got was that the patient was treated for some salivary gland carcinoma and radiotherapy was done. So just to confirm, in spite of doing PAS-PSD, we went ahead with these special immunohistochemistry, where PAN-CK was nicely positive, highlighting the LVSI here. CK7 was positive, indicating that it is a salivary gland carcinoma indeed. And DOG1 was positive with the luminal cells showing positivity for DOG1. So we went back to literature and we found that acinic cell carcinoma does have a propensity to metastasize way later on, that is even 15 to 20 years later. And they do tend to, have a propensity to recur in very, very rare sites. Like when I went through literature, I saw that over a span of, I think from 87 to 25, that's about 40 for 50 years, there seems to be about 9 to 10 cases with rare metastasis. The most common sites of metastasis are lung, liver, lymph nodes, and bone. But apart from these sites, there were a few rare sites that I just went and did a review of literature, and I found that there were sites that were there were cases where it has metastasized to cerebrum, to cavernous sinuses, and to the abdominal wall, cutaneous mets. But nowhere was it documented that there was an intramuscular soft tissue lesion, that too 17 years later. And most of these cases where these heart was one of the rare sites that it has metastasized to. And most of these cases where there were metastatic sites, there were at least one or two other common sites involved. But I think from the history, we could make out that in the past 17 years, the patient did not have any other metastasis. It was the patient had a lesion in the parotid, surgery was done, radiotherapy was given, and bam, after 17 years, they present with a rare lesion in the forearm. And when going through literature, we found out that the possible reasons could be because of any dormant cell, or it could be because the salivary gland neoplasms per se tend to have a very slow, very low mitotic index. They have a very slow proliferative index, or due to perineural invasion or hematogenous spread, they do tend to metastasize a little later on in life. So our take-home message is history is the most important factor in diagnosis, and delayed metastasis is a real clinical entity, and it poses its own diagnostic challenges in, especially in case of ethnic cell carcinoma, because ethnic cell carcinoma does tend to have a very long disease-free interval, which misleads the clinicians. In fact, in our request form, they had written a whole lot of history, but nowhere in the form was it mentioned that this patient had a history of salivary gland carcinoma. So that's how insignificant it seemed to them. So that is one point. Another point is that radiologically, the radiologist might not pick it up. They might still think of it as a benign lesion, or due to the odd site, they might consider a new primary instead of considering metastasis as one of the differentials, and they tend to have very non-specific clinical symptoms. So I think this was a very interesting case that which highlighted the importance of history and our interaction with the clinicians. So thank you.
Thank you, Dr. Lumila.
It's a patient is a male patient, no?
Female.
Female. Generally, acinic carcinomas are more common in male.
I think the propensity is that significant, ma'am.
No, but it can occur. Distant metastasis and late metastasis are more common in the salivary gland lesions.
Sorry, ma'am?
Late metastasis have come, but your case is the site is the very thing.
Very rare, yes. The site is the rarity.
Right. And you said history eliciting is most important. We have to dig out the history from the patient.
I do not know whether you people all remember, we presented a few meetings back about a pencil core granuloma. You see, that was also in the forum. And when it was a small child, about 8 or 12 years, and in the school fight, they were hit with the pencil, and that pencil lid had broken, and it has gone into the subcutaneous tissue and caused a granuloma. And it was all full of calcification and these kind of brown, blackish kind of a material surrounded by foreign body giant cells. And as she correctly said, we had to go and talk to the mother whether he had any trauma in the school. Then only we knew that they had a fight and the pencil core was stuck into the forearm. So as she said, I think eliciting, when we have a doubt, I think it is always better to have a proper clinical history and all the imaging modalities. Everything is very, very important. So I wish people realize the importance of history. Very, very important. Thank you for highlighting this, doctor. Thank you.
Your case was done in the Annanagar Sundaram Foundation, I think.
Yes, ma'am. Yes, the first initial time. The first time in 2009, yes, it was done there.
Yeah. Thank you so much. Thank you, Valavar.
Ma'am, thank you, ma'am. Thank you, Dr. Lumila, for stressing the importance of history, and that was a very nice case. Thank you.
Thank you, ma'am. Thank you, ma'am.
So we come to the fag end of the presentation. With that, the meeting is over. And thank you so much. Thank you all the participants. And thank you, ma'am, everybody, ma'am, Sita Lakshmi, ma'am, Sundaram sir, and everyone for all your valuable inputs. And so thank you so much, and have a great day. Thank you.
Valar, we should all thank you for a very fruitful and a very knowledgeable year with so many meetings. Very, very nice cases have been discussed. I'm very happy about it. Keep rocking, Valar. Keep going.
Thank you.
Today is the rarest of rare.
Thank you, Dr. Varmadi.
All rare.
Thank you, sir.
Best wishes for the new year.
Thank you, sir.
Thank you. Wish you the same, sir. Advance wishes.
Thank you.
Valar, I think the 50th meeting should be done in a grand scale with the publication of all the summary of all the meetings that you have had. So
Yes, ma'am.
get,
Yes, ma'am.
yeah, try to arrange for a sponsorship and
Yes,
arrange
ma'am.
in a some other area, some other location, so that all of us can meet in person and enjoy
Yes.
and it will be a real good gathering. So
After a
that's
long
just a
time.
Yes,
suggestion.
yes, ma'am.
So
This is 46th, so we have 47, 48, 41. 3 meetings to go. 50th
yeah,
meeting we'll definitely do as you said, ma'am. Yes, ma'am.
yeah,
Thank you so much.
please,
It should
yeah.
not clash with the annual APM. See that.
Ma'am,
Annual
it's not only,
APM, we should. Mm.
yes, ma'am, it's not only meets all our entire Stanley our postgraduates and all our people who helped me to go on with
Yeah,
this.
yes,
Thank you, ma'am.
yes.
Thank you
Okay,
so much.
okay,
Thank you.
Valar. All the
Thank,
best.
thank you, Valar, for conducting the city pathologist meet regularly.
Thank you, ma'am.
Sheba.
Thank you, Shiba. Thank you so much. Thank you. Bye.
Okay, bye.
Bye.